Yeah, and Dr.
Thanks.
Ritu is now going
Thank you.
to tell us more about how to adapt your EDOF IOL in your practice. Dr. Ritu, as everybody knows, is a very prolific cataract surgeon and runs her own successful practice in Noida. So good afternoon, everyone, and we'll be now talking a little bit more about EDOF IOLs, just to take it a little further from what Dr. Aditya has already said. And as we know, we're doing cataract surgery. It's no longer just removing the cataract. It is a refractive surgery. We can't escape that. And there's always a gap between what we think the patients want, but actually we are all on the same page. The doctors and patients are on the same page. The patient doesn't really know what he wants. He just wants to see well at all distances, and he'll come to you saying that he wants to reduce dependency on glasses because his neighbor doesn't wear glasses. And there are very few patients who actually say, I do want to continue wearing glasses even after surgery, but there are that 1% who do want. And what do we doctors want? We want our happy patients. We want that they should have good uncorrected distance, uncorrected near and intermediate vision. Patients should not come to us complaining of dysphotopsias. They should have a good contrast sensitivity. And they should keep referring more patients to us. And they'll do that only when they are happy with their results. So the multifocal presbyopia correcting IOLs have given us very good vision at distinct distances, good functional vision. But the problem is that there's always a compromise between the range of vision, the loss of contrast, the halo and glares. So we've been looking for an IOL which offers us the best of everything with a range of vision, minimal photic phenomenon, and high patient satisfaction. We know these optic principles about how monofocals work and how you get, a blur if you're looking at anything near or intermediate. Multifocality has also been spoken about by Dr. Anita, so I won't go into it. But the EDOF lenses, basically, they work on an elongated focus rather than discrete foci. They have an elongated focus, and so they give a more natural vision. So the aim is that you get a sharp, good image over a continuous range of distance. So you overlapping images that you get in multifocal lenses are avoided, and so the halo and glares is less. And this also avoids the secondary out of focus image, because basically in multifocality you have 2 or 3 images being formed, but there's a distance between the image, but the other image is always there. So the image quality is always at the expense of depth of field. I'm repeating this again and again. So how do you define this? It was seen actually that many of our monofocal lens patients, you find they are able to see near vision. How does that happen? Because they have a certain amount of pseudo accommodation. And this was seen, and this was actually inversely proportional to the pupillary diameter. So if you have small pupils, even monofocal patients are able to read well. And so the American National Standard Institute, they said that an EDOF IOL is an implant that provides an increased depth of focus compared to a monofocal IOL, with a superiority when it comes to the photopic intermediate vision, and it's non-inferior for distance vision. And the American Academy of Ophthalmology Task Force said that there should be within a one-line best corrected vision of a monofocal. And they should have a 0.5 diopter more of defocus as compared to a monofocal. And at least 50% patients should have better than 20 by 30 vision. Now, these are not a single kind of lens, EDOF lenses. Actually, they are, a wide basket of lenses. And the pure EDOF IOLs are those who are either spherical aberration based, or they're based on the pinhole effect. And most of what we call EDOF IOLs are now hybrid multifocal lenses. So the pure EDOF, as Dr. Aditya also said, is pinhole. Unfortunately, we don't have these lenses available in India, but they can be extremely good for post-keratoplasty patients or keratoconus patients where you have very, asymmetric corneas. So the pinhole effect can be very good in such cases. Then you have the spherical aberration EDOF IOLs. We have the Mini-Well from SIFI that is available. And basically, it's based on having positive and spherical. It plays with the positive and spherical aberrations. As we know, light, when it is getting refracted through, you have a positive aberration and a negative spherical aberration that can be created, and these lenses, they are based on that. So they give an extended depth of focus. These are hydrophilic lenses, work fairly well. I don't have too much of experience with them though. Then you have the enhanced monofocal lens, which came from Technis iHands lens. Again, it's based on a spherical aberration. It's basically a monofocal, giving a very little bit more of intermediate vision. But if you do a micro mono vision with these kind of lenses, they do work well. And again, it doesn't come at any negative, there's no side effects. So it's a very safe lens to use. So it's just like implanting a monofocal. So I'll skip the video. Then I've also been using the magnificent EDOF IOL from the Care Group. Again, it's a hydrophobic lens and it works like the iHands. So again, where your patient has less affordability, you can still offer them a very good result with these lenses. Then coming to the hybrid lenses, the Swiss EDOF lens, the Lucidus lens, again is a very nice lens to use, very safe. It's basically, it has a pseudo non-diffractive beam in the center, and this gives an extended depth of focus lens. It's like a plate haptic lens. It is a closed loop lens though, and these lenses center very well, and patient satisfaction with these lenses is very good. Of course, some patients do complain of a little bit of waxy vision at times, but generally they are happy. Again, from our Appa Swami, they have the Superphobe in focus lens, which is also a hybrid refractive lens, and it has a small central zone for near vision. Again, it is independent of the pupil because it's a small zone. So if you have a reasonably sized pupil, these lenses work well. And the Symphony, actually, which is a diffractive EDOF IOL, was the first one from FDA to be approved, and we've all had vast experience. But again, these lenses are not without the halos and glares, although it's much less. But patients can have these. And the advantage is the achromatic diffractive posterior surface. So that gives a the chromatic aberrations are much reduced. The AT Lara from Carl Zeiss, again, it's a plate haptic lens, and it is, again, it does have diffractive rings, 15 of them. So although these are considered EDOF, they're actually multifocal lenses which give you good distance and intermediate and a little bit of near vision. Now the Technis Synergy is actually a combination of a bifocal with an EDOF lens. Again, it gives very good vision at different distances, but again, it is a diffractive lens, so it does come with a little bit of a glare and halos, though it's much reduced as compared to the bifocal lenses. Alcon Vivity, I will not talk much, as Dr. Aditya has already told us about it. But again, I would say it's a pupil independent lens, minimal glares and halos, and patient satisfaction with these lenses is good. You can use it even in patients who have glaucoma, where you would not like to use multifocals, or patients who have ERM without macular edema. So your patient selection can become much wider. So why is the need for EDOF? Basically, we all trying to move towards presbyopia correction, and the new design concept is not to absolutely eliminate spectacle dependence, but to reduce it. And intermediate vision has now become so more important for us for our daily activities, and so we have a much more natural range of vision, fewer gaps, reduced photic phenomenon, and these are much more forgiving if you have any residual refractive errors. So in conclusion, we must, I think, try to see what all the lenses are available to us, what are the benefits, what are the downsides. Nothing can be as perfect as the human eye. And understand each lens that you're going to deal with, what are the pros and cons, tailor it to your patient, and try to do some mix and match or micro mono vision if you find that the first lens is not working well for your patient. Counsel them for neuroadaptation, and do a proper counseling to avoid any misunderstandings and over expectations. Thank you.
Thank you, Dr. Ritu. That was an excellent description of all the EDOFs available. So let's ask you, what is your EDOF of choice?
Well, I've been using the Vivity a lot, but it's again an expensive lens, so I don't think everyone can go
And if
for
cost
it.
is not put out, then
Yeah,
you
if
feel.
cost is not there, I think as EDOF, I would go for Vivity.
And how many here are using EDOF? Yeah, well, mostly everybody. Yeah. So are all the lenses included in what she said, or were there some more that people are using? Just
Yeah, as I mentioned, the Magnificent, and I think even Biotech has come out with an EDOF, and
and
APA is
the
also
upper
coming
one is
out. Yeah,
also quite good.
but Magnificent is a hydrophobic one and works really very well. And patients almost innate they do have. Yeah. Anyone
Yes.
else has a good experience with the Magnificent here? Yeah.
Upper in focus. Not very widely used, but I do have one patient who's quite happy.
Even Rayner has come out with the extended monovision. I've not, anyone has used it. I haven't had much experience with that. Yeah.
I don't find the eye hands as a very good. All my patients have 2.25, so I'm not happy with the eye hands. So I agree. Yeah. Yeah. Yeah, but mm, yeah. 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 Yeah.
I think whether it's EDOF or multifocal, any toric, I think more than 0.75, you need to correct it. Whichever way you do it, whether it is by doing any LRIs or doing a toric or, adjusting, as you said, on your Varion, you need to do adjustments because any residual astigmatism is, it degrades the vision quality.